Thank you very much for the invitation to present to your PSC Support Australia conference today. My name is Brooke Chapman and I'm a dietitian at the Liver Transplant Unit at Austin Health here in Melbourne. The topic of nutrition in health is quite vast, and especially nutrition in liver disease. So it's my pleasure to chat to you about PSC and nutrition today. This is a bit of an overview for my talk. First of all, I'll be talking about normal nutrition and liver function and metabolism. Then more specifically, look at some of the nutrition issues pertinent to PSC. We'll then cover some of the common micronutrient deficiencies, how these are diagnosed and treated. We'll look at inflammatory bowel disease with a bit more focus because that's quite common in people with PSC. And then finally, talk in a little bit more detail about muscle malnutrition, which becomes more important as liver disease progresses, and is certainly something that I encounter day to day in my work in the transplant unit at the Austin. So along with many other functions necessary to sustain life, the liver plays a really important role in processing much of the food and drink that we consume every day. And these key functions centre around carbohydrate and fat metabolism. So the liver stores most of the carbohydrates that we consume in the diet as sugars, and we use these for energy, and then releases this glucose into the blood whenever we need this energy, which is essentially constant. So we need glucose energy for us to breathe, for our muscles to move, for our brain to think and essentially live. So we're needing this constant supply of glucose 24/7. Importantly, the liver also produces bile, which helps carry away waste products in the body and breaks down fats in the small intestine, so assists in fat digestion. Specifically, also in a normal sense, the liver helps to maintain normal blood glucose levels of the body, so it helps prevent our blood sugar from falling too low or from getting too high. As I mentioned, it's a storage site of carbohydrates, and that storage form is known as glycogen. And if the liver is damaged in any way, then that storage of carbohydrates becomes significantly reduced. The liver normally releases that stored glucose as required, as I mentioned previously, which is quite constant, and particularly in periods where we're fasting or not eating. The liver is also can make glucose from other sources of nutrients, so it can make it not just from carbohydrates but from proteins or fats also. And as the liver deteriorates in function, the body needs to rely on these other sources of energy. So it can do this by converting protein from muscle or fat from stored fat into the glucose energy that the body requires. I've just listed here some of the common nutritional problems that we see in people with liver disease, and these include malnutrition, or weight loss or being underweight, fluid overload, which might be present as fluid in the extremities, so as edema or around the tummy as ascites. Nausea and vomiting or taste changes are also quite common in liver disease. And gastrointestinal malabsorption, which manifests as loose bowels or diarrhoea, is also quite common. And throughout the talk today, I'll focus more closely on malnutrition and the GI malabsorption, because these are most pertinent to the patients that I see with PSC. So firstly, I just wanted to start with that there is no such thing as a PSC diet or a one-size-fits-all approach. It is particularly important that everybody eats well, regardless of the degree of their liver disease. And this is because the nutrients that we get from food help the body to work properly. Your eating habits, of course, may need to change depending on your individual health at that point in time, your weight, whether that needs to remain stable or whether you need to increase or decrease weight, any treatment that you're going through or any side effects of that treatment, and tolerance to certain foods. And certainly if you're unwell with PSC, the principles of healthy eating might need to change quite significantly. also worthwhile noting that a majority of people with PSC also have concurrent inflammatory bowel disease. So, of course, specific dietary advice for this might need to be or will need to be followed, and also for any other conditions that the person might have, for example, whether that be diabetes or cardiovascular disease or high cholesterol or other food allergies or intolerances, so things like celiac disease or IBS, for example. Again, which just reinforces that an individualised approach is really important. So some general healthy eating principles though. So if you've still got good liver function or are early in the course of PSC, you may not need to adjust your diet at all, but just ensure that you maintain a healthy weight and have a balance and variety of foods from each of the 5 food groups. Note that no single food is bad for you or is forbidden or not allowed. It really relates to the frequency and the amount of specific foods that might need to be adjusted. So, of course, the 5 food groups I've got listed there. So, for example, fruits and vegetables, of course, provide an important source of fibre and vitamins, minerals and antioxidants. Carbohydrates and grains are essential for providing slow release of energy, and regular carbohydrate foods are really important if you suffer from fatigue or lethargy or tiredness. Milk and dairy provide some important, really important nutrients for people with PSC, so things like calcium, protein, as well as vitamins A and D and vitamin B12. Meat and other proteins are also essential in the diet and provide important building blocks for new tissue and for repair of tissue and for increasing muscle size and strength. And fats and sugars are listed at the bottom because these should be limited if you're eating well and maintaining your weight, or particularly if you need to lose weight to achieve a healthy weight, they might need to be minimised even further. Wanted to make note of a low FODMAP diet because this involves reducing the FODMAP foods that can cause adverse symptoms such as bloating or gas or a change in bowel habits like diarrhea or constipation. And a low FODMAP diet is usually used to treat IBS, but we know that these symptoms, that IBS type symptoms, are more prevalent in people with IBD and hence affect quite a few people with PSC as well. So that might be an important consideration for you too. Looking at fat digestion, as I touched on earlier, around fat digestion being important in liver disease and in particular in PSC, because we know that this condition makes it difficult for bile to flow easily into the bowel, and the bile is necessary to help break down and digest fats properly. So because of this, this maldigestion or being unable to digest the fats properly, it can result in a term called steatorrhea, which essentially just refers to fat being present in the stool. And it can be seen as stools which are pale, so very white or yellow in colour, that float in the bowl and may be difficult to flush. And symptoms of fat maldigestion can include things like nausea, indigestion or a feeling of fullness after a meal, typically if that meal has been high in fat, and smelly or offensive wind. It can result in a deficiency of fat-soluble vitamins and or significant weight loss. So hence it's really important to be mindful of and aware of and treat as necessary. And treatment of fat maldigestion includes restricting fats to a more tolerable level in the diet. So it might mean that needing to avoid very greasy meals or foods or deep fried foods. And to counteract that, you might need to increase the carbohydrate or protein content of your diet to ensure that you obtain all the calories and nutrition that you need. So micronutrients refer to the vitamins, minerals and trace elements that your body needs to function properly. And from a vitamin perspective includes both the water-soluble and the fat-soluble vitamins. The liver is an important storage and activation site for many micronutrients. So, for example, things like iron and copper and zinc are stored in the liver, as well as several vitamins, both fat-soluble and water-soluble vitamins. And the activation of some minerals and vitamins like thiamine, folic acid, and vitamin D also takes place in the liver. So an important site from a micronutrient perspective. And we know that micronutrient deficiency has been or is prevalent in almost half of all patients with advancing liver disease. In particular, for people with PSC, osteoporosis and osteopenia, which is bone thinning or bone loss, is quite common. And you can see in the diagram there the progression of normal bone health through to osteopenia, osteoporosis, and more severe osteoporosis, where there's weakening of the bones and where they become more prone to breaking and fracture if you fall. So osteoporosis and osteopenia are diagnosed with a bone mineral density DEXA scan, and it's well known that calcium and vitamin D help to strengthen our bones to an optimal level. So if osteoporosis or osteopenia has been diagnosed, then supplements of both calcium and vitamin D are often required. I've mentioned or talked quite a bit about the fat-soluble vitamins, so vitamin A, D, E, and K, and why these can become deficient in PSC. So regular monitoring of these via a blood test is necessary, and by regular, generally every 6 to 12 months is important. And where a deficiency is detected on a blood test, then a supplement might be necessary in the form of a tablet, or in some situations via injection, of which your doctor or gastroenterologist will prescribe. And just a recap of what those vitamins, each of those vitamins do. So if you have vitamin A deficiency, that can cause an impaired immune response, or so therefore make you more prone to infections and illness, or being less resistant to those things. Vitamin A deficiency can also result in night blindness. Vitamin D, as I've mentioned, is important for bone health, and particularly in a paediatric population, can be linked with poor growth in children. So important that vitamin D levels are optimal. Vitamin E deficiency is involved in many processes in the body, but in particular can cause nerve problems and muscle weakness. And vitamin K is essential in blood clotting. So if there is a deficiency in vitamin K, the blood can be less able to clot. So of course, bleeding both externally on the skin, but also internally can be more apparent. So really important that that's monitored and treated. Of course, IBD adds just an extra challenge to the management of liver disease in general, but in particular PSC. So just going back, of course, inflammatory bowel disease, or IBD, is an umbrella term for both Crohn's disease and ulcerative colitis. And it's a chronic and relapsing inflammatory disorder of the gut due to an abnormal immune response against the gut, the flora of the bowel, or the microbes and the bacteria in the gut, thought to be triggered by environmental factors in where there's a genetic predisposition for that. There isn't any evidence or a direct cause and effect relationship with diet yet, but certainly some associations have been made. And looking at things such as, in particular, the impact of Western diet, because the prevalence of IBD is more common in Western populations, so whether there's a dietary component to that. And also looking at a potential protective role of vegetable and fruit intake, whether there's something specific to those foods, or whether it's related to a higher fibre intake, and also in populations following a Mediterranean diet tend to have a lower incidence of IBD. Looking at, and one of the reasons that this is obviously an aspect of my talk is because inflammatory bowel diseases have quite a significant impact on a person's nutritional state and nutritional status. So I've got listed here some of the symptoms of IBD and or management of IBD and how that impacts on a person's nutritional state. So with things like malabsorption, loose stools, diarrhea. Obviously, there's malabsorption of some of the food and fluid that's being consumed. That might result in weight loss, which can be quite significant and place the person at risk of malnutrition or worsening malnutrition. Fluid and electrolyte losses can also be quite a common side effect of diarrhea or loose stools, and that are important to treat. Inflammation or fever can increase a person's nutrition requirements, can also cause a lowering or further lowering of albumin or protein levels in the body. Of course, if somebody has had to present to hospital, requiring a bowel resection or surgery for their IBD, there's going to be quite significant effects on their nutrition. So from both an absorption perspective, again, fluid and electrolyte losses become more difficult to manage. And also depending on the part of the bowel or the site of the bowel that's been resected. So for certain parts of the bowel are more important in absorbing and digesting certain vitamins, minerals, and foods and fluids. So, in particular, if it's related to the terminal ileum, there is B12 absorption can be affected, and other micronutrients. And steroid treatment, which is quite common as a treatment for IBD, is another medication that can thin the bones even further, so can worsen bone health and then result in increased prevalence of osteoporosis. So how do we manage these patients? So we look at sort of the acute phase. So when the IBD is active, or where there's a flare of the IBD, and at that time, a high calorie, high protein diet, generally requiring some supplements, some high calorie, high protein supplement drinks are needed at that time. A modification of the fibre content in the diet is often necessary in having either a low fibre diet or, as I said, modified fibre, because and the rationale for this is not to stimulate the gut any more than what we need to at that time, because fibre generally helps increase stool bulk and stimulates the bowel. So we want to try and reduce that need to go to the toilet at that time. But ensuring that fibre is then reintroduced as symptoms improve is really important. Adequate fluid and hydration levels are important to monitor and treat to prevent dehydration and impaired kidney function. A low lactose diet might be necessary for a period of time, also to help reduce diarrhea. In acute IBD, it can be difficult to digest lactose. So, of course, lactose being found in mostly in dairy foods, so things like milk and yogurt and cream in particular. And again, reintroducing that as symptoms improve. Vitamin and mineral supplementation might be necessary. And then, of course, enteral nutrition or parenteral nutrition might be needed if the person is unable to meet all of their nutrient needs through their diet. And enteral nutrition is essentially liquid nutrition through a tube into the stomach or the bowel, and parenteral nutrition is nutrition directly into the bloodstream that avoids the bowel. And those things tend to take place in a hospital setting. I've just got listed there exclusive enteral nutrition, which is EEN, or Crohn's disease exclusion diet, CDED, which are some specialised dietary therapies that are being used and getting increasing data or research taking place in these areas for helping to treat acute IBD. In the longer term, though, management of IBD is similar to that of PSC, where general healthy eating principles are encouraged. Good diet dietary variety, each of the 5 food groups, achieving, maintaining a healthy weight, micronutrient management, etc. The final part of my talk, my presentation this morning, was really to focus on muscle and malnutrition and how these things really matter and can make a difference in liver disease. So malnutrition is quite prevalent, quite common in liver disease, and much more prevalent than in other conditions. And there are many reasons for this, and some of those I've got listed here. And these include liver disease resulting in a high metabolism, so just essentially means burning more calories and protein than normal. So your body's working harder on the inside and needs more food to compensate for that. And that higher metabolism often occurs at the same time as reduced appetite or the person eating less because of many of the symptoms and signs that we've talked about already. So that feeling full, a slowing down of digestion, nausea, all of those things have an impact on appetite and your ability to eat and drink enough. Of course, coming in and out of hospital, fasting for tests, all of those things can also impact on nutritional status and the ability to eat enough for your current situation. But my job that I enjoy and what keeps me in business is that malnutrition is something that's modifiable and something that we can do something about. So looking to reverse it through small frequent meals, treating any underlying causes, adding in any medications if we can that might help with things such as nausea, bowels, etc. Prescribing high-calorie and high-protein foods and drinks, and potentially a change in the fibre content of the diet are all things that can help to treat malnutrition in liver disease and PSC. So does it actually make a difference? Well, yes, it does. There have been many studies that have shown that malnutrition negatively affects outcomes, not only in terms of survival, but also complications from liver disease. So it's really important to, first of all, try and prevent this in the first place, but certainly treating any unintentional weight loss, because the more weight that you lose, the less well-nourished the person becomes and the less well the liver can cope with that. And when you're not getting enough calories and protein, the liver has to break down your own tissues to get these nutrients, which does place extra stress on the liver. So nutritional therapy certainly helps improve the nutritional state, can help reduce the incidence of infection and decrease the time spent in hospital before and after surgery. So on a practical sense, what do I recommend, or what do I say to somebody who's losing weight unintentionally or becoming malnourished? So of course, we're trying to encourage, food first principles. So something we refer to as the adding principle, in trying to make every mouthful count, because it would be easy for me to say, okay, we'll just eat more, have a 3-course meal, or have an extra, extra slice of toast with breakfast, or an extra sandwich at lunchtime. But that actually isn't very helpful when there are sometimes so many barriers for you to being able to eat more and feeling too full. So we need to make the most of what you are currently eating. So that might be from adding extra high-calorie foods to your meal, or extra high-protein foods to what you're currently eating. So that might be adding in sources of fats in the diet, such as oils or extra butter or margarine, or swapping low-fat for full-fat dairy products. Although the caveat on that is, as I've mentioned, in those that do have fat malabsorption or fat maldigestion, that's not the first line of therapy that we would be looking at. Instead, it might be increasing calories in the diet through carbohydrates or sugars. Certainly increasing protein foods, and I've got listed sort of the 1, 2, 3 from highest, protein content that we're looking at adding in to meals. So it's all the meats, chicken, fish and eggs, dairy products or dairy alternatives if you can't tolerate dairy products, and some vegetarian sources of protein such as nuts, legumes and lentils as well. Drinks or nourishing fluids can also add in quite a few calories and important energy to the diet for those that have lost weight as well. So the hierarchy of the best fluids, to have when trying to maintain your weight include the supplement drinks, then anything milk-based or milk alternatives, and then the sugar-sweetened beverages like juice, cordial and soft drink. So an ideal eating pattern is having small, frequent meals and snacks over the day. And this is, small meals because often you feel full quite quickly, so you have early satiety, and frequent meals to try and minimise the time spent without food. And so essentially this is 6 meals or snacks over the day. So breakfast, lunch, dinner, as well as morning tea, afternoon tea and supper. The supper or late evening snack is the most important snack of the day because this is just before the body goes into its sort of longest fast, of course, overnight when we're sleeping. And studies have shown that having a late evening snack helps to improve protein balance and maintaining muscle. LBM is increasing lean body mass in the body, so that supper time snack is really important. Protein is a key nutrient, and people with advanced liver disease need double the protein of normal, so about 1.5 grams of protein per kilo of body weight. So if somebody weighs 70 kilos, needing about 100 grams of protein in the day. Obviously, if you weigh 50 kilos, that's about 75 grams of protein per day, adjusted for your body weight. And if we don't eat enough protein, then the body uses up its own stores of protein, which are essentially our muscle stores. And then that muscle wasting can lead to fatigue, lethargy or weakness, and reduced resistance to infection. So all things that we want to try and prevent. So which foods contain protein? So we can see here from the table that the highest sources of protein from sort of top to bottom there is your meat, chicken and fish. So 100 gram serve of any of those products gives you about 30 grams of protein. A couple of eggs, 12 grams of protein. A glass of milk or tub of yogurt or a handful of nuts is about 10 grams of protein, and so on and so forth down the table. And just at the bottom I've got listed there, so unfortunately our fruits and vegetables don't contain any sort of real significant protein content, so we don't sort of count those in the diet. Of course they have other important vitamins and minerals, but purely from a protein perspective don't tend to count those. And for those of you that may require supplement drinks or be in hospital needing some supplement drinks, an idea of how much these provide additional to the diet. So things like your Sustagen, Fortisip, Resource, anywhere from sort of 10 to 20 grams of protein. But also I wanted to highlight some sort of normal nourishing fluids and milk-based drinks that still can provide quite a significant amount of additional protein into the diet. So things like just an up and go, Big M's, flavoured milks, or even a milk Milo made at home is a good, almost 10 grams of protein being added into the diet. So practically, how does that work over the day? So if you were trying to achieve or if you were needing 100 grams of protein in the day, how can you reach that level? So again, you've got it broken down into the 3 meals and 3 snacks, but you can see there, there is a good source of protein at each of those eating times. So the cereal and milk provides 10 grams of protein in the morning at brekkie time. Morning tea, a protein-rich snack, so something like yogurt, or it might be a slice of cheese on a couple of dry bickies. At lunchtime in the sandwich or wrap or roll, some meat or tuna or a couple of eggs. It could be with some cheese. And a meat serve at night with whatever you might add to that, and then there's an additional protein source at supper time, there being, something like a sustagen, milk Milo, or it might be a, hot chocolate made with milk, to get to achieve around about that 100 grams of protein in the day. So thank you very much for your attention and time, and I'm happy to answer any questions in the Q&A to follow. Thanks.